Okay, imaging the painful hip, what has changed? In the next 30 minutes or so, we will be discussing the difficulty in evaluating the pre-arthritic hip, that is the hip before the appearance of osteoarthritis. We'll talk about biomechanical concepts as they relate to the pre-arthritic hip, and finally talk about common intra and extra-articular pathologies in the pre-arthritic hip, again before the appearance of osteoarthritis. So what has changed? First of all, we're treating younger patients, as I've said. Pre-arthritic. The biomechanics, we think we understand them a little better. I'll talk a little bit about the impingement concept and different types of impingement in the hip. I'll talk a little bit about a snapping hip. We have hip-preserving surgery, arthroscopy, endoscopy. Our patient population is younger. Athletes, they expect to return to play and not only pain relief. And finally, imaging has come a long way. But still, assessing the painful pre-arthritic hip is a clinical challenge. And why is that? First of all, there is an overlap of symptoms. Different pain generators present in the same fashion. And there are many pain generators in and around the hip itself. And while often the cause for the pain in the pre-arthritic hip is intra-articular, for instance a labral tear, oftentimes you'll have abdominal wall dysfunction, pubic bone stress reaction, adductor tendinopathy, Osseous pathology. And to complicate matters even more, not infrequently you will have two or more clinical entities in the same individual, and this has been shown on clinical and imaging studies. So why is that? Well, in some cases, this can be explained by the kinematic chain concept, which basically says abnormal motion in the joint impacts surrounding structures, for instance the labrum, but also may impact more remote structures because of abnormal motion and stresses. And this can be applied to the hip as well. And so when I approach the painful pre-arthritic or young hip, I ask myself two questions. One, what is the source? What is the underlying pathology here? For instance, is there abnormal bone morphology? And then, what is the secondary pain generator? And so when we image the pre-arthritic hip, the young hip, we use a multimodality approach because we have to evaluate both the bone, the osseous structures, but also the surrounding soft tissues. And our protocol includes radiographs, of course, pelvis, and dedicated hip films such as modified Dunn view, cross-table lateral, to look at the osseous morphology in addition to the fractures and so on. We also use a CT. In addition to the conventional sequences, we'll use a 3D shaded display to better show the morphology, and also a series of measurements, as you can see here. And let's see if I can use this without. All right. And for soft tissues, MRI is the imaging modality of choice, and MR arthrography for labral tears and labral pathology. When do we use ultrasound? One, when there is focal pain, we may use ultrasound. I'll show a case later on. And when there is a dynamic assessment, and I'll show you examples of snapping hip. Finally, we can use the MR. I'll use the ultrasound in some cases, or when I need procedure guidance. Now, let's talk about hip pathology. This is not a complete list. And when I approach the painful pre-arthritic hip, I think compartments. Is it arising from the joint or outside the joint? And if it's outside the joint, is it anterior, posterior, medial, or lateral? And this corresponds to the clinical presentation. The clinician will tell us the patient has lateral hip pain, please assess. And let's start with intra-articular pathology, and for that we have to talk a little bit about anatomy of the labrum, a key player. So the labrum is a fibrocartilage lining around the acetabulum, as you can see here. Can you hear me when I? Yeah. And it is contiguous with the transverse ligament overlying the cotyledonous fossa. It is closely attached to the hyaline cartilage through this transitional zone, and I'll mention that later on, but also closely attached to the acetabulum through a calcified cartilage layer. On imaging, MR and MR arthrography, the labrum typically has a low signal appearance, as you can see here, typically triangular, but can also be round or blunted. The transition zone, as you can see here, can have an intermediate signal, and in older individuals, the labrum may have an intermediate signal as well. So how do labral tears look on MR and MR arthrography? First of all, Increased signal. Here you have an MR arthrogram. You can see contrast in the joint. You can see a normal low signal labrum here, and you can see the increased signal in the anterior superior labrum consistent with a radial fibrillated tear. Another example, a contrast-filled cleft, fluid-filled cleft. Here are MR arthrographic images, sagittal and axial oblique. You can see contrast in the joint, and you can see this cleft involving the anterior superior labrum. This is a longitudinal tear with a partially detached labrum. A missing labrum is a torn labrum. Here's a CT arthrogram, sagittal and axial images. You can see contrast in the joint. You can see a well-defined posterior labrum. The anterior labrum is missing and is therefore torn. And this patient had claustrophobia, so we couldn't do the MRI. There's also associated pathology. Here's an MR arthrogram. There's contrast in the joint. It's sagittal. You can see this fluid-filled cleft along the anterior superior labrum, a labral tear. But then you can see this multilobular fluid signal lesion here. This is a paralabral cyst, which are associated with labral tears. These are of variable size, may or may not fill with contrast, so always look very carefully at your T2 weighted sequences. And these may grow significantly and could press on adjacent structures. So here you have this paralabral cyst with mass effect on the femoral vein here. So see a paralabral cyst, look for the labral tear in the hip. The problem with labral tears is they're quite common in older individuals and not uncommon in young individuals as well. So when I see a labral tear, I ask myself two questions. One, is the labral tear the source of the pain, and why did it occur? What is the underlying etiology? And what do I mean? Well, labral tears occur with osteoarthritis, trauma, dysplasia of the hip, but also impingement. And I'd like to elaborate on impingement, and specifically femoral acetabular impingement. So this occurs with abnormal morphology or morphologic variant of either the femur or the acetabulum, and is accompanied by pain on flexion and internal rotation with potential injury to cartilage, to labrum, to bone, and maybe predisposes to early osteoarthritis. Let's talk about the first type. This has to do with a femoral variance. It's called a CAM type. And what do we have here? We have this big old osseous bump replacing the normal spherical head here. Why does it occur? It's probably multifactorial, probably acquired as well. And what happens with flexion and internal rotation? This osseous bump meets the acetabulum and may injure both bone and soft tissue structures. Now we can see this osseous bump on imaging, on radiographs. You can see the osseous bump here and here on this done view and this cross-table lateral view. We can see that on CTs and MRs as well. Here's this osseous bump on the CT, on an MR arthrogram, and you can also see the accompanying labral tear. And we see this very, very well on the 3D shaded displays, and here you can see a very prominent osseous bump anteriorly, while posteriorly, and I'm sorry, the mouse here is a little slow, posteriorly you see the nice spherical appearance of the femoral head. Now, apart from subjectively seeing this osseous bump, we can also try to measure this. We have a measurement. It's a crude measurement, but it's what we have. It's called the alpha angle. Without going into the technical details, I'll say that there is intra-observer and intra-observer variability in this context, but we can apply this measurement on MRs, radiographs, and CT, and it will be part of our dictation, quantifying the degree of convexity of that spherical head. Now, so we have that osseous bump. So what? Okay. Well, just like a camshaft angle, the cam applies pressure, and this pressure may cause injury to that transition zone I mentioned, and this may cause tears. There could be tears on the labrum, as you can see here, and tears involving the hyaline cartilage loss on this MR arthrogram. So what do we do? And here I emphasize, in the proper clinical setting, when the physician thinks that there is clinical impingement based on physical exam and history, he will go in arthroscopically, remove the osseous bump in osteoplasty, so try to repair or at least trim down that labrum, so to get a stable edge. Again, in the proper clinical setting. Now, the other type of FAI, femoral acetabular impingement, has to do with acetabular morphologic variance or overcoverage. We have acetabular overcoverage in two settings. One, with acetabular retroversion, and two, with a deep acetabular socket. Now here's a schematic showing you acetabular retroversion compared to anteroversion. Retroversion could be focal in the anterior superior margin, as seen on the schematic here, or global, as seen in the schematic here. We can see retroversion on imaging. We can see it on a pelvic radiograph, and this is a magnification of a pelvic radiograph. It's called the crossover sign. The anterior acetabular wall crosses over the posterior wall, and this has been associated with retroversion. We can see retroversion on CT. Here's an example of a normal anteverted acetabulum looking to the front. And here is a retroverted acetabulum. So what happens when we have this retroversion or pincer FAI? Again, we have overcoverage in this case by this acetabulum, and on flexion and internal rotation, you may have soft tissue injury, labral injury. In addition, you may have posterior subluxation of the femoral head and have a contracute cartilage injury. And we may see subchondral marrow edema and subchondral bony changes involving the posterior hip, and cartilage loss involving the posterior hip as well. So this is the contracute sign, and it is considered a poor prognostic indicator in these patients. So what do we do in these patients? Again, any proper clinical setting, when a clinician thinks that there is evidence of impingement on clinical exam, he will go in arthroscopically and remove that extra osseous bump. Okay? And in this case, he also had an osteoplasty of a cam lesion. Now, the second type of overcoverage is a deep acetabular socket. We can see this in acetabular protrusio profunda, seen on radiographs and MR as well. The problem with this type of overcoverage is that it is circumferential all around that hip, and the surgical treatment is therefore difficult. Now I have to say a few words about the controversy as it relates to FAI. We have cam and pincer type morphology or abnormality in asymptomatic individuals as well. It is important to operate only on those based on clinical decision making, physical exam, and history. And when you look at post-surgical follow-up studies, they indicate clinical improvement in these patients, pain relief, patient satisfaction. The jury is still out regarding the impact on early osteoarthritis. Now, a few words about another type of impingement in the hip, which is non-FAI, and this is subspine impingement. This also has to do with osseous morphology, but in this case, there's a prominent anterior inferior iliac spine, or AIIS, which may impinge on the femoral neck on flexion and cause pain on hip flexion, limited flexion internal rotation without response to intra-articular injection of lidocaine or steroids. Why do we have this? What's the etiology? Well, avulsion injury, chronic traction in a younger individual, calcifications in rectus femoris tendon, pelvic osteotomies, and there's probably a developmental component to it as well. Yiftach Hetzroni and his colleagues at HSS showed different morphologies of the AIIS in different individuals with decrease in hip flexion in some of these variants. So what do we see on imaging? We may see post-traumatic changes, as you can see here. We may see calcifications in the rectus femoris tendon. We may see extension of the AIIS below the acetabular sourcil here. On CT and imaging, we may see distal inferior extension of the AIIS and cystic changes along the distal femoral neck where there is impingement. And what is the treatment? Again, the proper clinical setting, the surgeon will perform an endoscopy. Here's that bony excrescence. He'll go in with a burr and trim it down. So that is subspine impingement. Now, there are other intra-articular causes of hip pain, but due to constraints of time, I'd like to move on and talk a little bit about extra-articular causes of hip pain, and I want to start with the medial compartment and specifically athletic pubalgia. Now, why athletic pubalgia? One, it's a common mimicker of hip pain, and two, at times, athletic pubalgia is associated with hip pathology. Now, what is athletic pubalgia? It's a group of musculoskeletal lesions centered around that symphysis pubis, causing pain on activity and of variable etiology. And before we start talking about the pathology, a little bit about the anatomy. So the symphysis pubis has a central disc, and this forms a central primary cleft normally in the teens. And this joint is basically surrounded by reinforcing ligaments. But I want to emphasize one structure. There's a thin anterior capsule anteriorly that blends with a thick overlying aponeurotic sheet. And this is called the pubic plate in the center. okay? And this pubic plate is confluent with multiple structures. But again, I want to emphasize 3 structures. You've got the rectus abdominis tendon, you've got the adductor longus tendon, and the intervening layer called the aponeurosis. And this is called the rectus abdominis adductor aponeurosis. And so what happens, and you can see this on the illustration, you've got the rectus abdominis with its tendon, you've got the adductor longus with its tendon, you've got the intervening connecting aponeurosis here, closely associated with that pubic plate. And this whole structure is in balance. The muscles are in balance. Anything impacting this balance may cause pelvic pain and potentially may cause instability of symphysis pubis. And we look for this. So imaging-wise, what do we do in this context? Well, we can perform radiographs, a pelvic radiograph, or flamingo views with the weight bearing. And here you can see the malalignment, suggesting instability of the symphysis pubis. In the past, we used to inject the symphysis pubis with contrast to look for the secondary cleft, which is an extension of the normal primary cleft, indicating a soft tissue injury. Today, MR has replaced the need for injections. When we perform MR for this specific cause, we have one large field of view, but also small field of view images in the conventional planes, but also paralleling the arcuate lines to better see the symphysis pubis, the adductors, and the aponeurosis. And we emphasize the area of the aponeurotic sheath. So this is a sagittal, and again delay here, sagittal T2-weighted sequence. Here's your rectus abdominis muscle, the tendon. This is the area of the symphysis pubis in the aponeurotic plate. And here is the contiguous adductor tendons here. And here's an illustration showing you the same. And by the way, some of these beautiful illustrations are from Adam Zoga's many articles on this topic if you're interested. So what do we look for in imaging? First, we look for osseous changes, marrow edema, suggesting a subacute or acute component to it. The problem with marrow edema at the symphysis pubis, variable etiology, variable location, it is important to note accompanying findings, ossifieds, subchondral cysts, location of the marrow edema. And here's a case in point. This is a soccer player with anterior hip pain and groin pain. On this coronal stir sequence, you see this linear bright T2 signal in this location. And this patient also has a labral tear. And the thought here is that he's got abnormal gait and he's got a stress reaction in the pubic bone secondary to his abnormal gait in this athlete. Now we also look for soft tissue injury around the symphysis pubis, and specifically 2 types of soft tissue injury which are specific to the area and are seen in athletes. One is midline or pubic plate injury, and the other is the aponeurotic injury. So let's start with the midline or pubic plate injury. It's a breach, it's a tear involving the anterior capsule, which oftentimes extends and forms that secondary cleft, which could be bilateral and it could be asymmetric or symmetric, extending to the surrounding tendons and aponeurosis. There may or may not be accompanying marrow edema. Now there is controversy regarding the best treatment for this type of injury. It is complex. The other type of injury is that aponeurotic injury. In this case, the injury is not midline but off midline, centered at that aponeurosis we've mentioned. And what we look for on imaging is marrow edema at the pubic tubercle where the aponeurosis attaches. We look for tendon abnormality from tendinosis to frank tears, and we look for the secondary cleft. So here's an axial T2-weighted sequence. Here you can see the bright T2 signal cleft where the aponeurosis is attached, and it extends into the adductor muscles in this location. And this is associated or highly associated with the aponeurotic injury. And in this case, some articles have shown that surgical intervention helps these athletes. So this is a rectus abdominis adductor longus aponeurotic injury. So a few words about symphysis pubis in the hip. In some cases, symphysis pubis injury is associated with FAI. And the thought is that FAI limits the terminal hip motion and you've got abnormal stresses on the symphysis pubis. And here is a patient with a Pincer FAI, but you can also see the edema and fragmentation of the symphysis pubis in this young individual. So there may be a connection. And again, we're talking about the kinematic change, that concept of a joint abnormality impacting more remote structures. Having said that, you can have isolated medial compartment injury, adductor injury, without a symphysis pubis pathology. And this involves the adductor muscles or tendons, often when they're stressed passively or when they contract while lengthening. Risk factors are asymmetry between the adductor muscles or asymmetry between the adductor and abductor muscles on the same side. And we see this injury quite often in hockey players. And here's a great example. MR is quite good at showing the acute injury in this context. Here's a coronal stir sequence. You can see extensive edema involving the adductor compartment here. We don't do as well with chronic injury in MR. At times we'll perform an MR, it's hard to see chronic adductor injuries. And in this case, I may opt and perform an ultrasound if the patient can pinpoint the area of pain and it's proximal enough. And here's a case in point, chronic pain in an athlete. We can see a long axis ultrasound. This is proximal, this is distal. Here's your adductor longus tendon, and it is thickened and heterogeneous at its origin. So it's a chronic injury to the adductor here in this location. Moving on, lateral compartment. And here we're talking about the Adductor Complex. So we have the gluteus minimus attaching on the anterior facet, and we have the gluteus medius attaching on the superior posterior facet and the lateral facet. And there are also a number of potential bursas in this location. The largest one is the greater trochanteric bursa, deep to the gluteus maximus, overlying bone and tendon, but you also have the subgluteus minimus and medius bursa as well. Now, MR is quite good at showing us these tendons and bursa. Here's a sagittal and two coronal sequences. You can see the gluteus minimus attaching on the anterior facet. You can see the gluteus medius attaching on the superior posterior facet and on the lateral facet. Now, greater trochanteric pain syndrome is quite that, chronic pain and tenderness over the lateral aspect of the hip. And the path, we thought this was all bursitis, but now we know it's most commonly due to tendinopathy or tears of the abductor tendons or pathology of the iliotibial tract, which runs from the iliac crest to the tibia as well. And here's a case in point. This is an axial T2 weighted image. You can see high signal and thickening within and around the gluteus minimus tendon, consistent with tendinosis, partial tearing as well. You can also see a sliver of fluid in the trochanteric bursa just deep to the gluteus maximus muscle here. And in this case, we can see, this is a coronal stir sequence, you can see a partial thickness tear. Come on, mouse. All right. Partial thickness tear involving the gluteus medius. You can see fluid over the greater trochanter here and persistent fibers here, partial tear of the gluteus medius tendon. Now, the iliotibial band is also a cause of lateral hip pain, typically because of friction against the greater trochanter. And oftentimes it's associated with a snapping hip laterally. And ultrasound is really quite good at showing you that snapping, the dynamic component. So here you have a short axis ultrasound. This is the greater trochanter. Here's your iliotibial band, and hold your fingers. Let's see if the video works. When the patient rotates his hip, and it did work a minute ago. Okay, so when he rotates the hip, you can see the iliotibial band snapping over the greater trochanter, and this may be accompanied by pain as well. Moving on to the anterior compartment, we look at a few structures. I want to emphasize the iliopsoas. And why the iliopsoas? Because this powerful hip flexor is a primary cause of pain, both in acute and chronic settings in athlete. And when you look at the anatomy, the iliopsoas tendon is closely associated with the labrum, the pelvic brim, and this explains some of the pathologies we see here. Now, what pathologies do we see here? Apart from the usual acute muscle or tendon injury and tendinosis, I want to describe three specific pathologies: iliopsoas bursitis, iliopsoas tendon impingement, and iliopsoas snapping. So iliopsoas bursitis, it's a large bursa potentially between the tendon and the underlying pelvic bone and femur. It is the largest bursa in the hip itself. It may fill with fluid in the context of trauma, infection, or inflammation, and may look the same on imaging. Important to remember, this bursa may connect to the hip joint in 15% of the cases. So when you inject the hip joint with steroids, lidocaine, and get pain relief, it may have filled the bursa as well in the context of bursitis. So remember that. Here's a short axis ultrasound and a long axis ultrasound, and you can see this anechoic bursa partially encompassing the iliopsoas tendon, connecting to the hip joint, and it's quite a sizable bursa at that as well. Here's a CT arthrogram, and we can see contrast in the joint. However, it's filled the iliopsoas bursa as well because of that potential connection. So remember that when you inject the hip. The other type of iliopsoas tendon pathology I want to talk about is impingement. And when you see an isolated anterior labral tear without any evidence of FAI, impingement, dysplasia, trauma, osteoarthritis, you can consider the possibility of iliopsoas tendon either impinging on that labrum, which is just deep to it, as you can see here, tendon and labrum, or pulled by a scarred iliopsoas tendon, and that's called iliopsoas tendon impingement. Now, this is an arthroscopic diagnosis. However, if on the MR arthrogram you see an isolated labral tear at the 3 o'clock position without superior extension, with or without associated signal abnormality of the iliopsoas tendon and synovitis, you can raise the possibility of iliopsoas tendon impinging, pulling on that labrum, causing a labral tear. And the treatment here is tenotomy, basically, releasing that tendon. Now, the third thing I want to talk about in this context is a snapping iliopsoas tendon, a snapping hip in this location. Not uncommon. Younger female athletes and so on will come and say, we have a snapping hip. It could be painful. And again, we'll use the ultrasound in this regard. So here's a short axis ultrasound, and the iliopsoas will perform a rolling motion, and you'll see the tendon right here, this echogenic structure, snapping. And the patient may say, this is painful, and will be asked to inject steroids into that area to relieve the pain as well. So this is iliopsoas snapping, not uncommon. Moving on to the posterior compartment, again, there are a few structures we need to look at: the hamstring tendon complex, the sciatic nerve for neuropathy, but I want to specify and talk about two things. One, ischiofemoral impingement. Yes, another type of impingement. And finally, a few words about the sacroiliac joint. So ischiofemoral impingement is impingement between the proximal femur and the ischium, and it's associated with a narrowed, reduced distance between these structures, and it's accompanied by a muscle edema of the intervening quadratus femoris muscle in this location, a hip rotator. Now, why does this occur? Why do we have the short distance? Probably congenital. Females have this more than males. It could be post-traumatic or following surgery. It's primarily an MR diagnosis. Okay, so what we will see here is a pretty normal exam, but it's hard to appreciate, but there's muscle edema involving the quadratus femoris in this location, and this distance seems somewhat narrowed to me. Now, the clinical presentation here is pretty nonspecific, posterior hip pain. However, the MR will show you the edema in this location, and at times you'll be asked to inject at that location steroids and get some pain relief. Finally, the SI joints, although they seem remote for the hip, they can mimic and cause hip pain as well. And oftentimes they're associated, or not oftentimes, but sometimes in the young individual, they may be associated with hip pathology. Here's a case in point, a patient who had pincer type impingement, FAI, but on the coronal stress sequence you can see the marrow edema involving the left, the symptomatic side more than the right side. And the thought process here is, again, abnormal restricted motion in that left hip is causing a stress reaction in his SI joints and therefore pain as well. That chain reaction. So in summary, when you approach the painful pre-arthritic hip before osteoarthritis, use an algorithmic approach. Identify the osseous morphology. Look at it. Is it abnormal or not? Look at the surrounding and enveloping soft tissue structures, the labrum, the adjacent tendons, but also look beyond the hip at nearby joints as well. Think of that kinematic chain. Thank you.